Hi there, this is Chris Kiefer from the COVID Airway Safety course, and today I'm going to talk to you a little bit about equipment organization for the intubation of the COVID patient inside of a negative pressure isolation room. So to start off, I'd just like to stress how important it is that all of the essential equipment for the procedure goes into the room at once in an organized fashion so that we are not breaking the seal on our negative pressure isolation room to get other airway adjuncts and other equipment during the case. So you'll see in a previous video, which goes into the team roles, a description of each role in the hot team. And indeed in this video, I'm just going to emphasize which equipment each team member is going to be bringing into the hot zone. So your intubator is going to be in charge of bringing in the glide scope and the intubation tray, which will include things like your ETTs, your stylets, your syringe, etc. The ventilator role, the RT, is going to be bringing in the vent and a BVM, and they will bring their inline suction, their end tidal, possibly a PEEP valve and a viral filter. Lastly, your medicator is going to be bringing in your medications. And we found that it's very important to simplify this. If we have to urgently intubate a COVID patient, we don't have time to be mixing up a lot of different medications, particularly infusions, and to be thinking about bringing in a pump and programming it in the room. So we've really emphasized that the medications that should go into the room are push dose medications only. Okay, so this would include our RSI drugs. In the emerge world, most people are going to be choosing ketamine and rocuronium, as well as a push dose pressor. And we've chosen epinephrine as our push dose pressor. The reason being is that we are not going to be bagging patients during the apneic phase. And thus we expect that these orally hypoxic patients may well desaturate a little bit and possibly experience a bradycardic event. So we can prophylax or treat that bradycardia with epinephrine. In addition, it can be used to manage peri-intubation hypotension. Lastly, in terms of our post-procedure sedation, we can use a bolus dose, again a push dose of ketamine to bridge that patient for an additional 10-20 minutes until everything has been stabilized and another nurse can come in to set up our infusion sedation package. I should stress also that airway adjuncts for our plan B, C, and D are going to be kept outside of the hot zone. So if plan A fails, a request will be made, and for instance an LMA can be passed by the cold runner to the hot runner into the room. We strongly discourage stethoscopes to be used inside the hot zone. If a stethoscope is deemed absolutely necessary, it is stored again outside of the room in the cold zone and would have to be passed in. And that's really just to discourage their use. There's an enormous fomite risk here and we have to keep our providers safe. If we're worried about right mainstem intubations, there are other ways to prevent and detect those. Okay, so things like ensuring that the tube is at the right depth at the incisors, various vent settings like pressure and volumes will alert the RT to a right mainstem, as well as just visually checking for equal chest rise. Again, the reason that we are not bringing plan B, C, and D airway adjuncts into the room for every COVID intubation is that we are going to contaminate a lot of equipment if we do so. Okay, so that is how we focus on organizing equipment for the COVID airway safety course.